Okay, good. Hello, Dr. Clark. This is Raymond Woods, and this is my video for my head-to-toe assessment of a healthy adult. This is my healthy adult. Since I'm in New York and don't have anybody up here to help me, I'm going to do the best I can. Hopefully I can achieve a passing grade, and if not, please let me know, and I will try to find some people to help me out. But I've been unsuccessful so far. So, physical exam. First, I'm going to obtain the patient's height and weight. I am going to introduce myself. My name is Raymond. I'm a nurse practitioner student that will be doing your assessment today. How are you feeling? General overall appearance, looking at the patient, looking at the appearance, stated age, if what their skin turgor looks like, what their nutritional status looks like, obtain a set of vital signs. I would clean the stethoscope, and I would obtain a blood pressure, which I can't really do that on the bear, but I would do it there. Next thing I would do is obtain the radial pulse, and we can count that for up to a minute, but typically 30 seconds for regular rate and rhythm. And while you're doing that, you can not count the additional 30 seconds and actually catch respirations without them noticing that you're counting them. Record all of that information. The next thing I'm going to do is I'm going to proceed with the examination of the hands. I'm going to look at the skin color. I'm going to look at the turgor. I'm going to check capillary refill. I'm going to check fingers in between webs, looking for lesions. Have them do range of motion on their wrists. Then I'm going to proceed to the head. I'm going to examine the scalp, the hair in the cranium, the hair for distribution, cranium for any abnormalities. I'm going to look for anything that I see, and then I'm going to palpate the scalp and the cranium for abnormalities and document those as needed. The next thing I'm going to do is I'm going to look at the eyes. I'm going to check, do a visual acuity, and then I'm going to obscure one eye and check with insult, or check with finger movement to see on both sides. Hope you can see that. Cranial nerve 2. Then I'm going to turn on my, I don't have a pen light, so I'm using my otoscope light, but I'm going to do corneal reflex, same position in both eyes, looking for reflex. I can darken the room slightly. I can do a pupillary exam on both sides, and pupils are about 3 millimeters. They're equal, round, and react to light with accommodation. I'm going to examine the structures of the eye. I'm going to look at the eyelashes, the eyelids, the eyebrows, see if I see any deformities. I'm going to check the conjunctiva and sclera, the irides, and then I'm going to use my ophthalmoscope. I'm going to take my glasses off. I'm going to look in for the red reflex. I'm going to look at the ocular fundus. I see the optic disc that is got good margins. I can see the vessels in the posterior portion. I can see the macula looks good, and the rest of the background looks good on that side. Then I'm going to do the same thing to the other side. I see, I'm going to turn my light on. I see the red reflex. I see a good margins on the optic disc. I see good vasculature back there. And the macula looks good, and I don't see any cotton wool bodies or any other abnormalities in the eye. And the next thing I'm going to do is check cranial nerves 3, 4, and 6 with the 6 cardinal positions of gaze. I'm going to ask the patient to follow my pen light with their eyes. Up, right, down and right, down and left, left, up and left. Okay. Next, I'm going to inspect the ears for alignment. I'm going to look at the skin on both ears for any lesions or abnormalities there. I'm going to palpate the auricle and the tragus on both sides, and note for tenderness. I'm going to now look with my otoscope. I'm going to look at the external auditory canal for any abnormalities or lumps, bumps, anything like that. And in an adult, I'm going to pull the pen up and back, and then I'm going to look at the tympanic membrane, and it should be pearl gray in color. And on the left side, the cone of light should be at about the 5 o'clock position, the inferior lateral position. And I can see the mouse back there. We'll do the same thing on the other side. And on the right, the cone of light will be, I'm sorry, the left is 7 o'clock, the right is 5 o'clock. But it's inferior lateral. Sorry about that, I forgot to turn my phone off. It's on the other room whistling at me. So the next thing I'm going to do is I'm going to palpate the temporal arteries and the masseter muscle and have the patient open their mouth and close their mouth, check for the temporomandibular joint. Let's see. Then I'm going to palpate the maxillary sinuses for pain and the frontal sinuses for pain. And I'm going to go ahead and inspect the mouth with my light. Patient's going to open their mouth. I'm doing the best I can. Patient's going to open their mouth, stick out their tongue. I'm going to examine the hard palate, the soft palate, the tongue, the gums, the teeth. Look at the uvula. If tonsils are present, I'll grade them on 1+ to 4+. 4+ is touching in the center, and decreasing numbers with less swollen or less prominent tonsils. Look under the tongue, the buccal mucosa. Have the patient stick out their tongue and say ah to assess the uvula, and then stick their tongue out and down to assess cranial nerve 12, I think it is. I probably have that wrong. Next, I'm going to palpate the anterior cervical lymph nodes and preauricular. I'm sorry. Let's here. Preauricular, postauricular, submentum under the chin, submandible under the mandible, the superficial cervicals, the jugulo-digastric back under the ear. Have the patient turn their head, and I'm going to do the deep chain and the posterior on both sides. Next, I'm going to go around to the back of the patient. I'm going to have the patient take a sip of water. I'm going to palpate the thyroid, take a sip, and then swallow and see if I feel any nodules or any abnormalities there, any goiter. I got a box of Clorox there, it's holding the bear up. While I'm on the back, we're going to go ahead and I'm going to inspect the posterior of the back. I'm going to look for any skin lesions, any abnormalities. I'm going to put my hands on both sides of the chest, just below the ribs, instruct the patient to breathe deeply, and I will have them check for excursion or check for even expansion. Next, we're going to percuss, and I would percuss. I'm going to show you on the table first, just over the finger, a nice firm thump. I'm going to do the left upper lobe, the right upper lobe, and then the right kind of down below the inferior, the medial aspect on both sides. Work my way down the back. So I'm going to do here, here, and here, 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 and here, here, and then alternate sides, back and forth. Then ultimately, when I finish that, I'm going to percuss, tell the patient to exhale completely. I'm going to percuss till the tympani is gone, and make a mark. Have them take a deep breath, percuss again. Do that on both sides, and that's going to test for diaphragmatic excursion. We're going to come around to the front of the patient. I'm going to inspect the chest for equal expansion. Look at the skin for any lesions or abnormalities. And I didn't say, but on the back, when I'm listening, when I'm auscultating at the same locations that I percuss, I'm going to make sure that I listen to one full breath in and one full inhalation, one full exhalation at each location. I didn't auscultate the back, but I will do that now. And it's hard to, I'm going to use the bell since it's smaller. So I'm going to do here and here, here and here, and then I'm going to do right and left so that I can compare sides, and breath sounds are equal bilaterally with no adventitious breath sounds. Put my glasses back on. So I'm going to palpate the pericardium for the PMI, which should be at the 5th intercostal space, the left midclavicular line. Then I'm going to auscultate, I'm going to palpate the chest, and I'm going to have him, for egophonia, I'm going to have him say 99 on the upper lobes, the middle lobes, and then the lower lobe on the right. Then I'm going to percuss, as I did on the back, on all areas. Then I'm going to auscultate, breath sounds. 8 points of auscultation. These 3. And then here, and here, here, and here. Gosh, I hope this is okay. So then I'm going to listen for heart sounds. I'm going to listen for the, at the right mid-axillary line, 5th intercostal space, for any murmurs. And then on the left, and then the left sternal border. Okay, and then now I'm going to have my patient lie down. I'm going to inspect the abdomen for contour, for any abnormalities, any obvious ventral hernia. I am going to then auscultate in all 4 quadrants, starting in the right lower. Listen for bowel sounds. And then I can palpate for any bruits. And then with the bell of the scope, I can listen to the aorta, the iliac arteries, the renal arteries, I've skipped over those, and the femoral arteries. I'm going to then lightly palpate the abdomen, starting in the right lower quadrant, right upper, left lower. Then I'm going to do deep palpation to try to assess the liver, and deep on the left upper. Should not be able to palpate the spleen unless it's enlarged. I can put my hand back here and then push and feel if I feel the spleen. Will not feel the left kidney. Then on the right, you may feel the right kidney on some people. I'm guessing that it's going to be thinner people rather than fluffy people like me. I am going to percuss the abdomen. I'm going to percuss at the lower ribs and then percuss the liver. And the liver should be about 7 centimeters at the right mid-clavicular line. I think anything over 7 is considered enlarged. I'm going to set my patient back up. I'm going to go back, since I forgot to palpate the carotid arteries, one side at a time only, right and left. And then I can auscultate for bruit, if indicated, with the bell of the scope, and instruct the patient to exhale fully and do just under the mandible, about halfway down, and then just above the clavicle. Take a breath and repeat the same thing on the other side. On the chest, if it were a female, we would do a breast exam, and we would have her sit up first and then put her hands on her hips and then push down and look for equal flex upward in the breasts, and then she could put her hands up and they should come up evenly as well. Then when we lie her down, either on like whatever side we're going to do, we can put a pillow here, make sure she's comfortable, elevate the arm. We're going to palpate the breast, much like the abdomen, quadrant, like right lower, right upper, left lower. Palpate the areola and the nipple to make sure there's no discharge. And then we're going to palpate the tail of Spence and the axillary nodes. And we're going to do that on both sides, the same. If it's a male, you're still going to inspect the breast, because men can get breast cancer as well, much lower incidence. Have them set back up. I'm going to inspect the lower extremities. The bear won't set off the table. I'm going to keep the recording going, but try to turn it just a little bit. So we're going to have them bend their legs down. I'm going to inspect for symmetry. I'm going to then check for femoral pulses on both sides, popliteal pulse, which is right behind the knee, the posterior tibial, and the dorsalis pedis on both sides. I'm going to assess for temperature, and then pretibial edema. I have left some things out. I'm going to go back and add those in as I think of them. I hope that's going to be okay. A little nervous. So then I'm going to, I'm going to go back and I'm going to add in the Vibber test. I'm going to strike the tuning fork. I'm going to place it in the middle of the cranium. They should hear the sound equally in both ears, and that's going to be inducive of sensorineural hearing loss. And then I'm going to do the Rennie test, where we put it on the occiput, and then do an air conduction, and the air conduction should be about twice as long as the bone conduction. I know I've jumped around a little bit. I'm going to check for strength. Let's see. Oh yeah, let's do. Since I'm up here, I'm gonna go back and do that. Have the check range of motion of the neck. I'm gonna have them look right and left, up and down, and then I'm gonna have them look to the right against resistance and the left against resistance. Shrug their shoulders without resistance, and then shrug their shoulders with resistance. I also neglected to percuss the costovertebral angle, which would be about here. And if it were a person, I would put my hand here and then strike with a fist, and that'd be about here and here. A little lower, about there. So I'm going to go back to the legs. I've jumped around. Check in between the toes. I'm going to check the reflex, plantar reflex. The toes should flex downward. If they go up, that's a positive Babinski, which is a neurological deficit. I'm going to do the upper extremities, inspect, range of motion. I'm going to check the fingers. Did that. Then I'm going to elicit the deep tendon reflexes, brachial, and then the radial, and then the quadriceps, and the Achilles. In a female, if it was a male patient, start with a male patient. If it was a male patient, I'd do a genital exam. I'd check the penis, the glands of the penis for any discharge, abnormalities, or lesions. Check inguinal folds for hernia bilaterally. I would do a testicular exam. The testicles should be soft and non-tender with no lumps or tenderness to palpation. And the right should hang slightly lower than the left. If it's a female, we're going to do a speculum exam. Insert the speculum, open it. I've never done that. We're going to look at the cervix, take swabs from the endocervix. I'm going to remove the speculum, lubricate two glove fingers, do a bimanual exam. I'm going to palpate the cervix, put my hand up on the top of the abdomen, and move the cervix around, see if there's any tenderness, as well as inspect the wall for any abnormalities or lesions. And then you can do a vaginal rectal exam, new glove finger, one in the middle finger in the rectum, the second digit in the vagina, to check for any fistulas or any abnormalities there. When I withdraw my glove finger, if I have any stool, I can check that for occult blood, just to have that done. If it's a male patient, I'm going to have the male patient stand on the floor, elbows on the table, explain to him he's going to feel like he's going to have a bowel movement, but he won't. Insert a gloved, lubricated finger into the rectum. Feel the rectal wall for any abnormalities or fistulas or lesions. Palpate the prostate to see if there's any nodules and what size it is. Take that out. Again, if I have stool, I can check that for occult blood. And then I'm going to document all my findings. I know I've left a few things out. I look forward to hearing your feedback, and I'm going to try to recruit a couple of folks to help me out if I need to repeat this. Thank you.